Okay, hi everyone, my name's Katie, for those who don't know me, and today I'm going to be teaching PE and DVT. I've tried to make this as interactive as possible because I know most of you will know PE and DVT quite well already. So just what we're going to cover today is how to recognise it as an F1, how you're going to treat it, and then a few exam practice at the end. So, definition of VT, pretty simple. It's a formation of a clot in a vein, may or may not embolise. Why it's important, there's actually quite a lot of people who will die from these, or a lot of people that were getting well with them in hospital. You always hear about them in med school, but I know when I was on placement I never saw them. But having started working now, I don't know about you, Sufyan, but I see it quite a lot actually. So, causes or risk factors for developing a DVT and PE. Sure, you're all familiar with Virchow's triad. So first case, you're the FY1 on surgical on calls. You get a bleep half an hour before you're about to finish shift. Nurses bleeped you. Please will you see Mr. Jones? His family is worried that he's been more short of breath today. He's fine, but the relatives are making a fuss. Or you just come and have a look at him so they'll calm down. So he's a 62-year-old man who's admitted with right upper quadrant pain, nausea and vomiting. He's currently being treated for cholecystitis with fluids and antibiotics. Background is COPD, hypertension and prostate cancer. So you go to examine him, airway normal, respiratory rate 20, SATs 88% on room air, bearing in mind this guy's COPD. He's got reduced air entry bibasally, but no crepitations. He's speaking in broken sentences when he's talking to you and using his accessory muscles. His heart rate's 100, BP 110/65. So he's got a low-grade pyrexia. He's looking a bit dry, but otherwise fine. So who's worried about this patient? Hands up. Who's going to ask the nurse to repeat his obs and say bleep the F1 when they come on nights? No one? Okay. So his obs were a bit borderline. They were all just at the higher limit of normal, so I think you're all right to want to review this gentleman. So he says he's been struggling with his breathing since this morning. Normally he's short of breath when moving about, getting dressed, but today he's short of breath when he's talking. He's got no chest pain or cough, and otherwise no change in his condition. So what's your differential diagnosis? I've got some sweets here, so if you shout out a good one, I'll throw you one. Who said that? Who was that? Oh, sorry. Anyone else? Yeah, good. Oh, sorry. Yeah, why not? Oh, sorry, Kate. Any others? Yeah? Who is that? Okay, I am a girl, so it might not go as far. Okay, so the main differentials you'd be thinking of, obviously exacerbation of his COPD. He could have a hospital-acquired pneumonia or a PE, and as other people mentioned, the other ones, there's quite a long list. So what kind of things are people going to think about doing immediately? Chest x-ray, good. Yep. Anything else? Yep. What bloods are you going to do? Yeah, you could do cultures. Yep. Yep. Okay, good. Is anyone going to think about doing a blood gas maybe? Yeah. And how about a D-dimer? Is anyone going to do a D-dimer? So this guy's got cholecystitis, so his D-dimer will be raised anyway, so actually you don't need to do a D-dimer. D-dimer is quite non-specific, so it can be raised in quite a few different things. So I thought we'd do some slideshow practice. So let's look at this ABG first. Just have a few minutes to look through it and then we can go through it. Okay, everyone ready to go for the first one? So anyone want to shout out what you think's going on with this first blood gas? Respiratory acidosis. Yep. So is carbon dioxide's high, he's acidotic, so he's got respiratory acidosis, he's retaining CO2, so what picture is this fitting with this first gas? Exactly, so this, if you've got this blood gas on this patient, it's more pointing towards an exacerbation of his COPD. Next blood gas, what do people think of this one? So he's got a respiratory alkalosis, CO2's low, and he's hypoxic. So this is more fitting with a PE, and this was actually more similar to the gas that he had. Okay. Is everyone alright with that? Any questions? No. Back. Can you see here? They've got a deep S wave, Q wave here, and inverted T wave. That could quite likely come up in your slideshow. I'm pretty sure we had it in our slideshow actually. Okay. Another ECG. What can we see here? Something else you might see with a PE as well. So this is right bundle branch block, which you can see in a PE. Your William marrow. Okay. It's just another one showing that. Okay, for the bonus point, can anyone tell me what sign this is? It's Hampton's hump, which you can see apparently in PE. I've never seen it. I think it's a very rare one, but just in case anyone had. So, this guy, let's say he had S1, Q3, T3 on his ECG. Let's say he had the second blood gas, respiratory alkalosis. How likely is it he's got PE? Well, what you can do is also do a well score, which is going to determine what investigations you order next. So well score for a PE, you need to look at all these features which give you a certain number of points. If it's 4 or more, you want to do a CTPA. Less than 4, you need to do a D-dimer. Okay. You'd never be expected to know all this off the top of your head, but you know you can look it up on the internet or on your trust intranet, on your phone. So as I said, 4 or more, CTPA, or a VQ perfusion scan. This generally just depends on your trust, or for example, if you had a pregnant lady or someone who is allergic to contrast, you'd probably want to do a VQ perfusion scan. So if it's less than 4, you want to do a D-dimer. If that's positive, then consider doing a CTPA. If it's negative, then you can pretty much rule out that they've not got a PE rather. Okay. So, how are you going to manage a PE? Analgesia. If they're hemodynamically stable, you want to start them on a low molecular weight heparin. In jimmies, it's tinzaparin or enoxaparin if they're old or have got renal impairment. It'll vary trust to trust, so don't worry about remembering specific drugs. Just remember that you need to start them on a low molecular weight heparin. If they're hemodynamically unstable, you need to escalate it to your registrar because they might need to be considered for thrombolysis, but that's not a decision that you will make. And then in the long term, you want to start them on warfarin. If it's the first episode, it's only for 6 months. If it's recurrent, or I think if it's bilateral, then lifelong. Okay. So next, the FY1 on medical on-call. It's 11:15. Bleeps asked to see patient with a red swollen leg. So it's a 45-year-old man admitted with a community-acquired pneumonia and AKI. He's got a background of CKD stage 3, hypertension and diabetes. Since this afternoon, he's noticed that his left leg is swollen and painful. He's got no shortness of breath, cough or chest pain. So you look at his obs, they're all alright, pretty stable. His chest is clear, it's got good air entry bilaterally. However, when you review his drug chart, you notice he's got no prophylactic VTE prescribed. They've put the reason as mobile, but nursing staff inform you he's been bedbound for the last week. So, what you need to do when you're examining someone who you think's got a DVT is just qualify your judgment, because even if you think they haven't got a DVT, you need to give clear reasons why. So, I always measure and put the measurement of both legs. What you should do as well is actually draw out the area with a surgical pen if it's red. So his left calf was 38 centimetres, right calf 34 centimetres. Does anyone know what the significant difference is where you start thinking it's more likely? 3 centimetres it is. So if there's a 3 centimetre difference, that's when you want to worry. So diagnosis, DVT. And again, you can use the Wells score, it's different for DVT. For a Wells score for DVT, if it's 2 or more, straight to ultrasound scan, 1 or less, D-dimer, okay. And again, you wouldn't be expected to know all this off the top of your head, so don't worry about it. So as we said before. Again, management, analgesia, low molecular weight heparin. Also, you need to monitor for signs of a PE. If you've got high suspicion that they might have a PE as well, then they should have a CTPA at the same time as they go for the ultrasound scan. Again, with the warfarin, if it's their first episode, 3 to 6 months. If it's recurrent, then they need to be on it for life. Right, so we've got some MCQ practice. So if you want to just take 5 minutes to work through those. Everyone happy? Yep. Okay, so shout out. Number 1, what do you think? Yep, good. Forgetting to throw out my fruit. Who said cellulitis? Everyone. Have it. Oh, sorry. Getting a bit aggressive with these fruits. Number 2. Yep. And question 3. Yeah. Look at the Wells score. It says here you get 3 points if an alternative diagnosis is less likely than a PE. Well, that's the case here, so he's already scored 3 for that, so straight to CTPA. And that's it. Any questions? No? All right then, thank you.